Welcome to this explainer. Okay, today we are unpacking a really compelling, totally rigorous working paper titled Photonic/Spectroscopic AMR Fingerprinting. Basically, we're looking at how to finally detect antimicrobial resistance without that traditional agonizing wait. Let's jump right in. Here is our roadmap for today. We're going to cover the AMR diagnostic crisis, fact-check the quantum hypothesis, look at pathogen panels and paired comparisons, walk through the 5-phase research plan, lay out the non-negotiable scientific safeguards, and finally, explore the future healthcare pathway. Section 1, the AMR diagnostic crisis. So antimicrobial resistance already kills more people every year than HIV or malaria. It's massive. But the real bottleneck? It's structural. Right now, we face this devastating wait time of 24 to 72 hours for conventional culture and antibiotic susceptibility testing to actually give us usable results. I mean, we're talking about 1 to 3 whole days just to grow the organism and figure out what kills it. And during that waiting period, clinicians are put in a terrible dilemma. They either have to delay life-saving treatment, which, can rapidly worsen patient outcomes, or they prescribe antibiotics empirically. Basically, they're forced to guess. And that unnecessary or incorrect antibiotic use, it literally fuels the exact resistance we're desperately trying to fight. So every single technology that shortens this window attacks the AMR problem right at its root. Section 2, fact-checking the quantum hypothesis. To solve this massive bottleneck, researchers naturally started looking at advanced sensors. Now, the original, highly speculative idea was that AMR bacteria passively emit this unique, species-specific quantum signal, kind of like a photonic barcode that we could just look up in a catalog and read directly, while the bacteria is just sitting there at rest. It sounds absolutely amazing, right? Well, we have to be radically transparent here. That passive quantum signature concept, it's just not supported by published evidence. First off, there is literally no published catalog of species-specific quantum signatures. It doesn't exist. Second, while ultra-weak photon emission is a real thing in bacteria, it's really just a generic byproduct of their metabolism, not a specific fingerprint. And finally, current quantum sensors usually require engineered magnetic tags to work. They aren't just passively reading untagged bacteria. So, what does the published evidence actually support? Well, we do see documented, reproducible biological differences. For example, bacteria showed distinct variations in electrical conductivity using dielectrophoresis, shifts in autofluorescence under antibiotic stress, and molecular vibrations using Raman spectroscopy. So the absolutely crucial takeaway derived from all these validated methods is this: resistance is best detected through a controlled perturbation, not some passive signal measured at rest. We have to measure how bacteria respond to stress, whether we hit them with an antibiotic, a temperature change, an electrical field, or a pH change. That response? That is where the true fingerprint lies. Section 3, pathogen panels and paired comparisons. The working paper outlines a very specific initial bacterial panel to study. We're looking at Escherichia coli, Pseudomonas aeruginosa, methicillin-resistant Staphylococcus aureus, or MRSA, and carbapenem-resistant Enterobacterialis, known as CRE. Now, it's super important to note that CRE is a broad resistance category. It's not a single bacterial species, so the exact organism has to be strictly defined in the research protocol. And this is exactly why paired comparisons are vital. We absolutely have to compare susceptible strains against resistant strains of the exact same organism. For instance, comparing a susceptible MSSA against a resistant MRSA, or a susceptible E. coli against a carbapenem-resistant E. coli. Doing this isolates the actual resistance mechanism from all that confusing background biological noise. We need to be 100% sure the machine is seeing the resistance, not just identifying the species. Section 4, the 5-phase research plan. This framework is perfectly designed to systematically test the equipment without jumping to any premature conclusions. Phase 0 reproduces known baseline patterns just to prove the equipment actually works. Phase 1 records those baseline signals. Phase 2 introduces those controlled perturbations we just talked about, like antibiotics, and watches how the signal changes. Phase 3 unleashes machine learning to see if those response patterns can accurately identify resistance. And finally, Phase 4 validates everything by comparing our results with the absolute gold standard of laboratory culturing using strictly blinded samples. Section 5, non-negotiable scientific safeguards. To prioritize research validation over immediate commercial deployment, these safeguards guarantee scientific honesty. There can be zero claims of a unique quantum signature without first-hand reproducible evidence. Results absolutely must be compared with laboratory reference standards. Every single experimental variable must be strictly standardized. And I actually really love this last point. Negative results are highly valuable. Why? Because they tell us exactly which technologies or signals are not clinically useful, which saves so much time and resources down the line.
Section 6. The Future Healthcare Pathway.
So what happens if this all actually succeeds? If we can successfully and instantly identify resistance through these photonic and spectroscopic fingerprints, the entire clinical workflow is completely transformed. That agonizing 72-hour wait, it's over. In the future, this sensing equipment could become a separate diagnostic support module connected to something like a Prima kiosk. First, Dr. Maya AI would seamlessly collect the patient's story, symptoms, signs, and exposure history. The kiosk then processes all that contextual infection risk. Then, the diagnostic module steps in to rapidly identify the pathogen and its resistance profile based on the physical fingerprint, all without waiting for a culture.
I'll leave you with this final thought. The post-antibiotic era doesn't just arrive as a single explosive event. It arrives one delayed diagnosis at a time. To conquer the global AMR crisis, we have to first conquer the diagnostic delay. Beating the post-antibiotic era starts with ending the 72-hour wait. Are we finally ready to flip the script on how we diagnose infections? Thank you for joining me for this explainer.